Knock.
Hello.
Hey, my name's Jared. I'm going to be the nurse practitioner student doing your assessment today. We're going to be focusing on your cardiovascular and your respiratory system. And we're going to kind of go through and just assess all the different parts of those and go from there. You have any questions for me?
Nope.
Let me wash my hands real quick. All right. Can you tell me your name and birthday?
Clay Mitchell, 7/22/95.
All right. And do you consent for this to be used as educational video?
Yes.
All right. We're going to get you to remove your shirt. All right. We're going to start with the posterior side of the chest. So if you'll turn around for me. All the way. So the camera can do a good view. So initially we're just going to inspect the skin. We're looking for color, temperature, moisture, turgor, lesions, scars, nevi, and temperature. So his skin it looks pink. It's warm and dry. There is no lesion, scars, nevi, or edema noted. He does have good skin turgor, rises and falls appropriately, indicating he has proper hydration. Next, we're going to move on to the inspecting his AP diameter, which on inspection his AP diameter is 1 to 2, which is appropriate in an adult, or appropriate, which is an appropriate assessment finding. Next, we're going to kind of inspect and look at how he's breathing. His respiratory rate is normal. There are no audible wheezes noted. He's got no cyanosis noted. Let's see what else. I think that's it on the inspection part. He's not in any distress. He's not coughing. If he was coughing, we would assess the sputum and what it looked like, its consistency and all that. He's not showing any respiratory distress, tripoding, anything like that. No use of accessory muscles. I think that's going to be it on that one. Next, we're going just kind of his chest is symmetric bilaterally. We're going to inspect look for chest expansion. Placing our hands right here, we're going to pinch some skin up right here. I want you to take in a deep breath and let it out. Again. Can't really do it anyway. Turn a little bit. Try it again. And again. I don't know if you can see I got the skin pinched. Okay. So his chest expansion is normal. Both lungs expand and come back together equally. Next, we're going to assess for tactile fremitus. So I want you to say 99.
99.
Again.
99.
Again.
99.
And again.
99.
All right. And we're just assessing if there was any increased vibrations noted on one side or the other. That would indicate consolidation, pneumonia, stuff like that. So next we're going to move on to percussion. We're going to percuss over his lung fields, and we should hear resonance over the lung fields. So we're going to which there is resonance. You get down here, you get a little dullness. Okay. So his percussion exam is normal. There is resonance over the lung fields, dullness over the solid organs in the back. Let's see. So next we're going to auscultate lung sounds on the posterior side. Doing so in a hook and ladder or a hook ladder fashion, using the diaphragm of our stethoscope. I want you to take a deep breath in and out. Again. 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 And again. Okay. Unable to hear any tracheal sounds. He does have bronchovesicular sounds in his upper chest, and then vesicular sounds over the lung fields. His lungs are clear and equal to auscultation bilaterally. There's no wheezing, rales, rhonchi, or any other adventitious lung sounds noted. Next, we're going to listen for egophony, and we want to make sure that he's going to be saying the letter E, and we don't want to hear the E sound. If we did, that would indicate that he has a consolidation in that area. So we're going to move on and go to egophony. So I want you to say the letter E.
E.
Again.
E.
Again.
E.
Again.
E.
Again.
E.
Again.
E.
Again.
E.
And again.
E.
Okay. There's no defined letter E that when auscultating. So his egophony exam is negative, indicating that there are no consolidations in his lungs. Next, we're going to move to bronchophony, which is the same with just we're going to use words. We're going to go with 99. So I want you to say 99.
99.
Again.
99.
Again.
99.
Again.
99.
Again.
99.
Again.
99.
Again.
99.
And again.
99.
Once again, no defined words are heard. It's just a muffled tone indicating that he does not have any consolidations, and therefore his bronchophony exam is negative. Next, we're going to move on to whisper pectriloquy. And in this, he's going to whisper the word 99, and we're going to assess to see if we can hear it, or if we don't hear anything at all. So, or if we just hear a buzz. So, can you go ahead and whisper 99? Again. 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 And again. All right, nothing's heard, so that whisper pectriloquy exam is negative. Again, indicating he does not have any consolidations noted there. We're going to also, while we're on the posterior side of his chest, we're going to palpate for CVA tenderness. We're going to percuss for CVA tenderness. So costovertebral angle would be approximately right here, and we're going to do it by percussing on his back. Is there any pain?
Mm-mm.
Any pain when I do that?
Nope.
All right, so his CVA tenderness is negative, which indicates that if he was positive for CVA tenderness, you could have some sort of kidney infection or pyelonephrosis, something like that, pyelonephritis. I think that's it on the posterior side. Now we're going to move around to the anterior chest. So I want you to turn around for me. Once again, we're going to start off inspecting the skin with the temperature, color, moisture, turgor, edema, texture, bruising, lesions, nevi, and scars, which he has none. He has even hair distribution on his chest. His chest is symmetrical. There's no increased work of breathing noted on the anterior side of his chest. His like I said, his respiratory rate and rhythm is normal. let's see. Now we're going to palpate, or excuse me, we're going to do tactile fremitus on the anterior side of his chest. So I want you to say 99.
99.
Again.
99.
Again.
99.
And again.
99.
All right. And so there's no increased vibrations noted on any of his on him saying 99, which would indicate that he does, or which would be suggested that he does not have any consolidations there. Let's see. What else? Now we're going to re-auscultate on the anterior side. All lung fields. All right, can you take a deep breath in for me? And out. In. Out. Again. 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 And again. Okay, so he has on the anterior auscultation, he has clear and equal lung sounds bilaterally, no wheezing, no rales, rhonchi noted. He has tracheal sounds in this area, bronchiovesicular in this area, and then vesicular over the lung fields, which is normal. Some cardiac stuff now. We're going to auscultate his heart sounds. So we're going to auscultate 5 different areas with the diaphragm of our stethoscope. So we're going to auscultate the aortic area, which is second intercostal space, right sternal border. Then we're going to go to pulmonic, which is left sternal border, second intercostal space. Herb's point, which is the third intercostal space, left sternal border. Tricuspid, right sternal border, fifth intercostal space. And then mitral, which is fifth intercostal space, mid-clavicular line. Then we're going to go back through and do the same thing with the diaphragm of our stethoscope. Aortic, pulmonic, herbs, tricuspid, and mitral. And on auscultation, we do not hear any rubs, murmurs, gallops, anything like that. S1 is heard. S1 and S2 are heard only. S1 is heard more predominantly at the apex, and S2 at the base, or at the base. Is like I said, there's no murmurs, frictions, friction rubs, gallops, or any other adventitious heart sounds noted. And then we are going to identify and palpate the point of maximum impulse, which would be mid-sternal line, approximately fifth intercostal space, which is appropriate. Then we're going to auscultate for 1 full minute for his apical pulse. All right, so 1 full minute's passed. Rate is normal at 78. Rhythm is regular, no gallops or anything heard, no irregularities heard on his heart on the auscultation there. At this point, we're gonna change positions and have him lay down, and we will pick back up with the video here in just a minute. All right, so now that we have him, our patient laying anywhere from 30 to 45 degrees with the head of the bed up, we're gonna inspect for any heaves or lifts, which I do not see any. We're going to palpate for thrills over the auscultation points. So we're going to palpate over the aortic area, over the pulmonic area, over Erb's point, over the tricuspid area, and over the mitral area. And I do not feel any thrills on auscultation, or any thrills on palpation. Next, we're going to repeat his heart sounds and using both the bell and the diaphragm of our stethoscope. Starting with diaphragm, or starting with bell. So we're going to go aortic, pulmonic, Erb's, tricuspid, mitral, and then we're going to flip around to the diaphragm of our stethoscope. Again, aortic, pulmonic, Erb's, tricuspid, mitral. Again, S1, S2 heard at all sites. S1 more predominant in the apex, S2 more predominant in the base. We're going to now assess for JVD, or excuse me, his heart rate is regular, or his heart rate is normal, rhythm is regular, no gallops, murmurs, or anything like that. Next, we're going to check for JVD with his head, with the head of his bed. We're going to get him to turn his head. I'm having to do it backwards because I can't get my camera angle right, but we're going to look for the point of venous flow. We're going to mark that and come out to his sternal notch and see where it lies on our chart here, which is going to be at 2 centimeters, which was within normal limits. Anything under 4 centimeters is considered appropriate. So this time we've completed our cardiac and respiratory exam, and we'll go back and discuss the findings with the patient. So overall, your assessment is very normal. There's nothing that I would have any cause to order any other tests for right now. Your heart sounds are normal. You don't have any kind of wheezing, crackling, or anything like that in your lungs. So right now we're just going to have you follow up in a year's time and have another physical done, or come back sooner if you have any complaints or any kind of concerns.
All right.
So do you have any questions for me?
Nope.
All right. Thank you so much. Pleasure to meet you.
Thank you.
And we'll see you next time.
All right.
All right.